The Centers for Disease Control and Prevention, CDC, defines standard precautions as the minimum infection prevention practices that apply or that should be applied to all patient care, regardless of suspected or confirmed infection status within the patient, in any setting while healthcare is delivered. Standard precautions involve body fluid precautions and body substance precautions. Isolation should be used when performing procedures that may require contact with blood, body fluids, secretions, excretions, mucous membranes, and non-intact skin. Standard precautions include hand washing, gloving, protective equipment for personnel, needle recapping, and biospills or safe practice of cleaning up spills. Hand washing is the best and most effective method for preventing and controlling infections. Hand washing should be done before and after contact with patients. Gloves are worn to prevent contact, spread of infection during any invasive procedure. Personal protective equipment, or PPE, includes the use of gown, mask, fluid repellent gowns, eyewear. Needle recapping should not be performed unless absolutely necessary. If used, the one-scoop method should be employed exclusively, and the needle should always be disposed of in a sharps container. In the case of biospills, gloves and appropriate PPE must be used. Transmission-based precautions are in place to avoid infection transmission by contact, airborne, and droplet transmission. When transferring patients with a communicable disease, the recommendations are such: mask the patient, cover the patient, and clean the room after the patient leaves. If dealing with patients with virulent pathogens that spread through direct contact with other patients or healthcare providers, technologists should wear gloves and wash hands before entering and leaving the room. Gowns are needed when in contact with the patient. Technologists should remember to clean all contaminated equipment after leaving the room. Patients leaving the room should wear a gown and a face mask. In case of Staphylococcus aureus, it is a common infection that can be spread through contact. A gown is necessary only if in contact with the patient. All contaminated equipment must be cleaned after leaving the room, and the patient leaving the room should also wear a gown and a face mask. All contaminated clothing should be removed in this order: gown, gloves, wash your hands, then remove your mask. Airborne precautions are used for patients who have a disease that can spread through the air. These patients must be placed in a negative pressure isolation room with the door closed. Healthcare workers entering the room should wear respiratory protection, such as an N95 filtered mask. The mask filters the inspired air. Patients leaving the room must wear a surgical mask to filter the expired air. Droplet precautions are used for patients who have a disease that can spread through droplets. These pathogens spread through large droplets expelled when a patient coughs, sneezes, or talks. They can travel up to 3 feet in the air. Patients are placed in a private room with the door closed. Any healthcare provider entering the room should wear a mask if standing within 3 feet of the patient. Patients leaving the room should also wear a mask. Protective or reverse isolation is used to prevent microorganisms from entering the isolation room. It is used on patients who are immunocompromised. For example, patients suffering from severe burns would fall into this category. Care should be taken to thoroughly clean any equipment before entering the patient's room. Now we will review the surgical procedure section. Anyone working in a sterile environment must wear the appropriate sterile gown and gloves. Gowns and gloves are put on after the surgical scrub is complete. The surgical scrub consists of 2 minutes of hand-washing technique employed by surgeons and anyone else on the surgical team. Gowning and gloving can be done in 2 ways: self-gowning or gloving and gowning another person. After the gown is on, only the sleeves and front of the gown down to the waist are considered sterile. To maintain sterile technique, once in a sterile gown and gloves, individuals must pass each other back to back instead of front to front. The sterile scrub consists of scrubbing with an antimicrobial agent for 2 to 3 minutes. The surgical scrub removes debris and transient microorganisms from the hands, nails, and forearms to reduce the resident microbial count to a minimum and to inhibit a rapid rebound growth of microorganisms. A typical surgical scrub could be performed with 2% chlorhexidine or a 7.5% providone iodine. Gloving can be donned by 2 methods: self-gloving or gloving another person. A sterile surface is always required for sterile gloving. The process for self-gloving is as follows. First, you open the glove package by the flaps as shown in figures A and B. Next, you pick up the glove by its inside cuff with one hand. Be careful not to touch the glove wrapper with your bare hand. This is shown in figure C. In figure D, you will see how you slide the glove onto the opposite hand, leaving the cuff down. Next, using a partially gloved hand, you slide the fingers into the outer side of the opposite glove cuff, as shown in figure E. Next, you slide the hand onto the glove and unroll the cuff. That is shown in figure F. In figure G, you will see that with the gloved hand, you then slide the fingers under the outer edge of the opposite cuff and unroll it gently, using the exact same technique. The procedure for removing sterile gloves focuses on avoiding contamination. The procedure is shown in the following graphics. 1. Grasp the edge of the glove. 2. Unroll the glove over the hand. 3. Roll the glove in the other hand. 4. With the bare hand, grasp the opposite glove cuff on its inside surface. 5. Remove the glove by inverting it over the hand. And 6. Pull off and discard the glove. When performing an invasive or surgical procedure, the area must be microorganism-free. Any item added to the field must be sterile, clean, and dry. Expired or already open items are not considered sterile. A sterile field is therefore a microorganism-free area that can receive sterile supplies. Never lean over a sterile field. After the field is set, it is covered and draped, ready to use. When the field is ready for use, the first step is to confirm that the field has been unaltered and that all the packages are still sterile. The sterile corridor is the area between the patient drape and the instrument table. The technologist should never cross into the sterile corridor. The sterile pack is a package containing instruments or material that has been sterilized. Dropping contents gently onto the sterile field from about 6 inches above the field at a straight angle ensures that they stay sterile. This technique helps ensure that the package wrapping doesn't touch the sterile field at any time. When pouring sterile fluids into a sterile basin on a sterile table, you must hold the bottle with the label uppermost so that poured solution cannot stain and obscure the label. Always confirm the name of the solution with the surgical team members before pouring. The sterile basin into which the sterile liquid will be poured is generally placed at the end of the sterile field to avoid splashing over the entire sterile field. With as little of the bottle as possible over the field, hold it at a height of approximately 6 inches over the sterile basin. Pour the solution gently so that no splashing occurs. Splashing of liquids can destroy a sterile field by allowing microorganisms to move from the unsterile tabletop through the wet drape that forms the bottom of the sterile field. Bottles containing sterile solutions are usually considered sterile on the inside, but contaminated on the outside. Once opened, use only once and then discard. When opening sterile packs, make sure that the package is clean and dry, that it has not been opened, and that the expiration date has not passed. The process is as follows. A. Open the back flap first. B and C show you then opening the side flaps. In Figure D, you see that the front flaps are opened then. You always must check that the sterile packaging device is intact, proving that the package is sterile. In the next few slides, we will learn the difference between aseptic and non-aseptic procedures and detail some of these procedures, such as urinary catheters, NG tubes, urinals and bedpans, and enemas. First of all, it is important to know that non-aseptic techniques do not require sterile conditions. It is a non-sterile procedure and can be used for tubes and lines into the digestive tract in order to remove some body waste, such as enemas, or for enema contrast examinations. A urinary catheter is a tube inserted into the bladder using the aseptic technique. In most instances, the radiologic and imaging sciences professionals do not catheterize patients. There are 2 main types of urinary catheters, the indwelling and the condom. There are 2 types of indwelling catheters, the retention balloon or Foley and the straight catheter. Straight tip catheter tubes are used to obtain a specimen or empty a bladder and can be easily inserted and removed. Balloon tip catheters can be left in place to allow continuous drainage of urine. They have an inflatable balloon at the tip to prevent accidental removal. For example, the Foley catheter has a balloon tip that can be filled with sterile water to hold the catheter in place. Condom catheters are sleeve-like catheters used on males. They do help prevent infection. However, because they go over the penis, they are not as secure. For catheter insertion, the female patient is placed in the lithotomy position with knees flexed, thighs abducted, and rotated externally. Male patients can lie supine with legs abducted. Catheter insertion is not performed by the technologist. However, the technologist may play a supporting role and should always ensure patient privacy. The Foley catheter can be used for various purposes, such as bladder emptying before or after a procedure, relieving bladder retention or incontinence, or bypassing an obstruction, irrigating the bladder, introducing drugs into the bladder, to permit accurate measurement of urine output, or to relieve incontinence. If a patient is given anything to drink in the radiology department, this should be recorded. Also, if the radiographer empties the urine collection bag, the output must also be measured and recorded, unless otherwise noted. To secure the catheter, the tip of the catheter is placed in the urinary bladder and the catheter tubing is taped to the inside of the leg. The tubing ends in a calibrated drainage bag. The drainage bag must be always kept lower than the patient's bladder to prevent backflow. The technologist may be asked to remove the catheter. Medical aseptic conditions should apply. Always wash hands and wear gloves. Explain the procedure to the patient and provide the patient privacy. If a balloon catheter is used, the balloon must be deflated before removing the catheter. Nasogastric tubes, or NG tubes, are plastic or rubber tubes inserted through the nasopharynx into the stomach. The insertion is performed by a physician or nurse. For any NG insertion, the patient must sign a consent form. The NG tube can be used for the administration of medications and gastric decompression, or the removal of flatulence or gas, as well as fluids from the stomach, after an intestinal obstruction or a major trauma. Care must be taken to prevent accidental withdrawal of the tube after it has been inserted. A chest X-ray can be performed to check the NG tube placement. The physician or the nurse can perform a preliminary check by attaching a syringe to the end of the tubing and pulling gastric fluid back. The tube is usually taped to the patient's face to prevent accidental withdrawal. When NG tubes are used for gastric decompression, they are typically connected to an intermittent gastric suctioning device. Always confirm that the physician has given an order allowing the transfer and interruption of suctioning. Suction must be reestablished in the radiology department if the patient can be connected for a short amount of time. The NG tubing is a double lumen tube. Therefore, the clamping of the tubing is not recommended. Clamping could destroy the lumen of the tube. Urinals are plastic or metal containers that are used for portable urination. They are used for male patients and can be disposable or reusable. The male urinal is shaped so that it can be used by a patient who is supine, lying on his right or left side, or in the Fowler position. If urine output is being tracked, the technologist should confirm the urine volume after the patient urinates. The bedpan is used for male and female defecation or for female urination. If the technologist is helping a patient use the bedpan, the patient's privacy and comfort should always be respected. There are two bedpan designs: the regular and the fracture bedpan. The fracture bedpan has a unique wedge-shaped design. It is not as high as the regular bedpan and allows the patient to be elevated slightly for placement. It also has a convenient handle for placement and removal. Enemas are used for bowel cleansing and to promote defecation. An enema could be given to outpatients and can be self-administered. Enemas would be the required preparation for a contrast barium enema examination. To be effective, enemas should be given until there is clear return, meaning that the enema fluid is expelled without fecal matter present. Enemas can be made of plain tap water, although this is not often used. The hypertonic solution in a fleet enema is more common. A hypertonic solution is a commercial solution that pulls water from the interstitial spaces around the colon and into the colon. A saline enema is the safest because it has the same osmolarity as the interstitial spaces of the colon. This is often used on children. A soap suds solution will promote peristalsis and defecation, but it may irritate the bowels. The oil retention enema is an oil-based solution. Oil is retained and absorbed by the stool to promote defecation. It needs to remain in the colon for 1 hour to soften the stool for easier evacuation. Osmolarity determines osmotic pressure, which controls the movement of water in the body. Higher osmolarity contrast pulls water to them. A hyperosmolar solution will have a high osmolarity and draws water to itself. This will cause dehydration. A hypoosmolar solution has low osmolarity. Excess fluid goes to interstitial spaces, leading to fluid toxicity. The barium enema involves the administration of an enema of barium sulfate solution into the colon via the anus. The study is used to help diagnose pathologic conditions of the colon or lower gastrointestinal tract. The barium enema catheter may have a plain tip or an inflatable cuff attached. After the tip is inserted, the cuff is inflated to hold the catheter in place to prevent involuntary expulsion of barium. The technologist may be required to insert the barium enema tip. This is performed under medical aseptic conditions. The patient is placed in the Sims or lateral position. Always lubricate the enema tip. Ask the patient to exhale slowly and gently insert the tip into the rectum and toward the umbilicus. This tip should not be inserted more than 3 or 4 inches, and we never force the tip in. After insertion, the tip is attached to the tubing and to the enema solution. However, before attaching the tubing, all the air in the tubing should be displaced by opening the clamp and allowing the barium to run all the way through the tubing and to the tip. Barium sulfate is used because it has a high atomic number and allows for optimal contrast. It is available in prepackaged powder or pre-mixed liquid forms. The prepackaged powder must be mixed with water before use. When mixed with water, barium sulfate forms a suspension, which means it will separate on standing. The water should be at room temperature to avoid irritating the bowels. Mixing water with 2 teaspoons per 1,000 milliliters of salt can prevent fluid overload. The barium bag can hold up to 3,000 milliliters of barium suspension and up to 500 milliliters. It should never be placed at higher than 30 inches above the table or the patient. During the study, the patient should relax their abdominal muscles to reduce intra-abdominal pressure. Deep oral breathing can be used to prevent spasms and abdominal cramping. A double contrast barium enema involves using barium and air to coat the inner walls of the colon. This is helpful in diagnosing polyps and is used on patients with a history of colorectal cancer, rectal bleeding, or other conditions where the colon mucosa needs to be visualized. On the radiograph, the barium is seen as white areas and the negative air contrast is seen as black areas. For the procedure, only a small quantity of barium is administered, followed by air. The patient is turned into various oblique positions to move barium into colon compartments. Fluoroscopy imaging allows the visualization of the anatomy. Single contrast barium enema uses a larger volume of barium. After fluoroscopy imaging, the excess barium is drained back into the bag. The tip is removed and the patient is sent to the bathroom to evacuate as much of the barium as possible. Post-evacuation images can then be taken. Single contrast studies can be used to evaluate fistulas, acute appendicitis, diverticulitis, volvulus, and it's often used on patients who are disabled and have a hard time turning onto their abdomen and put into multiple positions. Barium sulfate is inert, but it is not water-soluble. Therefore, it cannot enter the bloodstream. If there is any suspicion of perforation, anastomosis, megacolon, Hirschsprung disease, or any risk of barium impaction, barium suspension cannot be used. Barium is also not recommended for post-surgical patients. The alternative contrast is gastrographin. Gastrographin is an iodine-based water-soluble contrast. It is hypertonic and will draw water to itself. The contrast may cause diarrhea and reduction in blood volume, and it could be dangerous for infants and patients with Hirschsprung disease. The cuff of the barium tip must be deflated before the catheter is removed. At the end of the study, allow some of the barium to flow back into the bag before assisting the patient to the bathroom. Assistance is necessary because many patients may feel dizzy after the procedure and they are prone to falling. Patients should be instructed to increase fluid intake and dietary fibers for several days after the study unless medically contraindicated. Barium is naturally hygroscopic and can cause patient dehydration. The patient should be warned that their stool will appear white. Some patients may need to take a laxative, and the patient should be advised to consult their physician if they do not have a bowel movement within 24 hours of the study. A colostomy is performed when a portion of the colon is removed. It can be permanent or temporary. Generally, the colostomy is located on the descending sigmoid or transverse colon. Colostomy patients may need a barium enema. A special enema tip is used with a smaller catheter and less barium is used, approximately 250 milliliters. Patients should be given instructions to irrigate the stoma the night before and morning of examination to prevent expulsion of feces for 24 hours. Laxatives or dietary preparation will vary. The patient should not take bismuth tablets, which are used to reduce odors, because these are radiopaque. The patient should be instructed to bring an extra pouch to replace the soiled bag after use. Diabetic patients on insulin should be advised to forego insulin intake until after the examination. The rule is no food is taken, then no insulin should be administered. In a surgical setting, the technologist must pay strict attention to sterile techniques, identify the surgical team and the float nurse, and communicate clearly with the operating room staff. Always be aware of the sterile corridor and respect its dimensions. When using the C-arm in the operating room, a sterile drape may be wrapped around the C-arm, or a shower curtain wall drape can be used to protect the sterile environment. C-arm draping can be accomplished using snap covers, shower curtains, or draping the site with additional sterile cloths. In neonate imaging, there are 3 primary concerns in addition to acquiring the image. Protection of patients from infection because they have immune systems that are immature or compromised, and they are prone to infection. We must maintain strict medical aseptic conditions by washing hands and wiping down equipment before and after handling patients. Preterm babies in isolettes need to be kept warm. Their body temperatures may fall very quickly. Imaging should be performed in the isolettes whenever possible to maintain a warm environment for the patient. Always position the X-ray unit first, select your technique, and cover your detector to further reduce the heat loss. Only then should you position the patient. In addition, many neonates can tolerate minimal handling without their heart rate slowing too much. The technologist needs to take extra care when moving tubing and other equipment. With an open incubator, it is easy to simply push the heater out of the way to take an image. With a closed isolette, the front or sides will open and you can remove the bed tray to slide your detector in and out. This chapter would not be complete unless we covered COVID-19. This is the first global pandemic our generation has ever had to deal with. COVID-19 is a type of coronavirus, other known as SARS virus, specifically SARS-CoV-2. Coronaviruses are very common viruses that cause infection in the nose, sinuses, and upper throat, or in the lower respiratory system, trachea, and lungs. Many of the symptoms of COVID-19 are very similar to those in the common flu, and a lot of comparisons to the flu have been made. But COVID-19 is not the flu. It is much more virulent, and it is unpredictable. While we know that the flu is more likely to cause serious complications in the elderly and immunocompromised, COVID-19 complications are much more deadly and have killed otherwise healthy people, not just vulnerable persons. COVID-19 symptoms vary widely from person to person, with some experiencing no symptoms whatsoever and others experiencing severe complications, ending up on respirators with severe pneumonia and sometimes dying. It is the fact that people can carry COVID-19 and not have any symptoms and it is the fact that we cannot know how a person's body will react to the virus once infected. COVID-19 is not an airborne disease, but because of its virulence, we do use protective measures that go beyond those measures practiced for the flu and other forms of coronavirus. When working with patients infected with COVID, healthcare workers wear N95 masks. Eye goggles or shields are used to prevent the virus from getting into the eyes, which communicate with the upper respiratory system. All patients wear a mask, and the masks are worn routinely by all hospital workers. There are two other well-known coronaviruses, MERS and SARS, which are also significant concerns to global health, but the total number of deaths from these viruses do not compare to the number of people who died from COVID-19.